Hello, Protruserati. I'm Jazz Galati, and welcome back to another episode of Protrusive Dental Podcast. Today, we're joined by Dr. Javier Quiros from Costa Rica, who is one of the best dentists I know when it comes to composite resin artistry. This guy's been doing it for so long to such a high caliber. I look at his work and I think, wow. And I want to basically piece apart his thinking process, how he uses composite, what are the best ways to get the maximum results using composite resin, and what are the sort of limits, when should you consider ceramic, which is a theme we've covered before on the podcast, but it's always great to have new perspectives. And what I gathered after recording with Dr. Quiros is that he's very pro-composite, but he's also someone who's placed, thousands of units of ceramic as well. So he can give us the lowdown on them both. Some of the main themes we cover in this part 1 episode, because again, it's one of those amazing episodes that is full of so much value that I had to split it into 2. And you guys voted for it on the Protrusive Dental community and on @Protrusive Dental Instagram page. I gave you a couple of options. I gave you composite additive equilibrations, and I gave you high-end cosmetic rehabilitations. So one was like more occlusion based, one was more actually composite as a material itself, and you guys selected composite for this round. So after the part 2, then I'll release the one about additive equilibration with the composite. So that'll be a really good one as well. But for this one, the kind of themes we cover in today's episode is how much can you lengthen teeth safely with composite, which is kind of an occlusion question as well, but it gives us some guidelines to follow in terms of what substrate, what kind of composite, and planning your occlusal design and smile aesthetics. I asked Dr. Quiros' experience on how long composite veneers are lasting. He's been doing it for about 20 years, so let's hear it from him. With his patient base, how long do they tend to last, what are the kind of issues, and at what point do they happen? And we also cover the theme of what kind of case is best suited to the young dentist. So a few years qualified and you're starting to do more anterior composite work. Perhaps you're doing just basic restorations, or you're going to go for some composite veneers or edge bonding. What is the ideal case to start with? Because you want to go with baby steps, right? I mean, I'm a big believer in that. You want to go for the most complex edge-to-edge bite composite veneers. You want to start off with the easier, low expectations, low lip line kind of thing. So we cover that kind of basis. The Protrusive Dental Pearl I have for you today is a video that I'm going to play for those watching, but for those listening, you'll easily catch what I'm trying to say with this pearl, which is the use of what we call the Casi 3C instrument. There's a couple of varieties of this, but I've shared this before on this podcast. It's an instrument distributed in the UK by Enlighten, who are the sole distributors of Cosmodent products. And if you're around the world, then find your Cosmodent dealer, because they have this particular instrument. Now, what I love about this instrument, and I'm playing a video for those watching, but for those listening, I'm actually building up a lateral incisor freehand, okay? I'm not doing a wax up, I'm doing kind of like a mini rehab here. I've just done a canine riser, and now I'm building up the upper lateral incisor. And I'm, instead of using my finger, like I used to use my glove finger, then I used to use like a mylar strip phase, and now I use this Casi instrument because it's got a perfect spade shape with a curve in it that beautifully forms the lingual or palatal contours of your incisors. So because it's a non-stick material, I've placed that up against the lateral, and I'm literally using it as my stent, my palatal stent for my composite, holding it in place. And I'm using another one of these same instruments, but the other side of it, which is a very thin, again, beautifully curved instrument, and it's actually designed for you to also use it with composite veneers. So this instrument, I like it so much because it's got that sort of 3 planes on it that really allows you to adapt the composite in a way that it creates those correct angles and emergence profiles that you need. So I'm a huge fan of this instrument. So once again, that's the Casi instruments. These are designed by one of my buddies, Dr. Carlos Sanchez. Now, interestingly, it's Dr. Carlos Sanchez whose episode we'll be looking forward to next, talking about additive equilibration. So it's nice how that one weaved in. But he designed this instrument, and I've been using it for a few years now since I attended the mini smile makeover course with Dipesh Palmer, because that's where I learned how to use it, and I'm just absolutely loving it. I want the world to know how much I like it. So that's my big tip. If you're looking for a composite instrument, this is my favorite instrument. So if you look in my box of instruments, I've got about 3 or 4 of these specific ones. Because another tip that Payman Langrudi gave me is that instead of buying 8 different instruments, buy like multiple of the one instrument that you absolutely love using. So I keep my composite protocols very simple. So this is the main instrument I use, and it comes in a sort of smaller, thinner one as well, which is great for like lower in size and stuff. So check out the Casi instrument. I'll put the links in the show notes, protrusive.co.uk, so you can get to those easily. And now let's get to the main episode, and I'll catch you in the outro. Dr. Javier Quiros, all the way from Costa Rica, welcome to the Protrusive Dental Podcast. How are you, my friend?
Very good. Thank you, Jazz. I'm very honored to be with you and with all your listeners.
I mean, I told you this last time we briefly met. We had to reschedule this recording because there was a storm. And when I say storm, most countries would laugh at the UK and say, you call that a storm? It was for us, it was a big deal, but for the rest of the world, they were laughing at us. But we rescheduled, and I was speaking to you briefly then, and it's just an honor to have people, the caliber of dentists like you, listen to the podcast. It just drives me wow, I can't believe that. So thank you so much for your listenership and joining now the community to help and support on a pretty big topic, composite versus ceramic, which I'm really excited to delve deeper in today. But for those people who haven't seen your wonderful work before, don't know much about you, please introduce yourself, Dr. Javier Quiros.
Well, I'm Javier, and I'm from Costa Rica, and I am a restorative dentist. I also a prosthodontist, and I work here in Costa Rica. I teach, and I'm a wet finger dentist. I see maybe from 5 to 10 patients per day. And I do a lot of full mouth rehabs and a lot of aesthetic dentistry. And today, what I would like to share with you guys is my experience of over 20 years of teaching and private practice about which material to choose whenever it comes to cosmetic dentistry and full mouth rehabilitation. So thank you, Jazz, for your kind invitation.
Guys, we're in for an absolute treat. I know it. Just behind. So those of you who are listening, don't worry. Javier listens to the podcast when he's on the treadmill, so he appreciates that.
Yes.
If you're just listening, if you're driving, if you're chopping onions, he will make it very descriptive for you. But for those of you who are watching it, oh my goodness, you get to see the beautiful work that Javier does. But Javier has promised that he's going to make it really descriptive, and really tangible. So even if you're not watching, it's okay. You're going to get the real deal. So let's start with a big question straight off the bat. Let's start with bigger picture before we niche down. Why is it that in the last, for me, I think I really started to notice composites go huge in about 2013 when I was qualifying, and I started to see more and more from that point, composite veneers going quite big. What drove those trends, and what about you as a wet-fingered practicing clinician for over 20 years? At what point did you start saying, okay, wow, this composite stuff, it works well for veneers? When did that shift happen for you as well?
Jazz, I started like everybody else. I thought my lab technician could solve my problems. And so I just prep teeth and send that impression to my lab technician and hope that he could solve all the aesthetic problems that my patients were having and build those smiles like I would imagine them too. But you know what? I was very disappointed when I saw that my lab technicians could not make a smile the way that I wanted to. So I started looking at composite veneers. And then I had an epiphany. It was that if I didn't learn how to make teeth myself, just not my lab technician, but myself, then I will never be able to do a great smile on my patients. And so I started first doing porcelain, but then my lab technicians would do something else that I didn't want it to. So I first do them in composite, then prep on top of composite, and then my lab technician only had to do a very thin porcelain veneer, and I would bond it on top of my composite. But then I was doing the work twice, Then I find out the wonderful material that is microfill composite, which is a very thin layer that I put on my veneers at the end, microfill composite. And that looks just like enamel. It looks just like feldspathic porcelain. And so that was my trip. It's been 20 years. So I started with full porcelain. Then I moved to feldspathic, then composite and porcelain. And now I do microhybrid composite and microfill composite on top. And you know what, Jazz, I'm an independent dentist. I don't rely on my lab technicians for them to build the smiles. I'm the sole responsible of how my patients look at the end of our appointment. And I'm so happy and I'm so free because of that. I have all kinds of experiences with my lab technicians. I was doing maybe 1 or 2 cases of porcelain veneers per week. And suddenly my lab technician just doubles his fee. Or suddenly my lab technician says that he didn't want to do any more feldspathic because he bought a CAD cam. And now I had to prep 3/4 crowns because his CAD cam would not read my preparations because they were too conservative. So
I mean, sounds like it was born out of frustration initially,
yes,
and then it evolved
yes,
into
it
an artistic form for you, and then it gave you full control. Now, you mentioned a few important things in there. Now, a lot of my listeners will know about the difference between microhybrid composites and microfill, but for those who don't, please, can you just explain the chemistry a little bit behind them and why microfills have such beautiful polishability? Like the one that I'm aware of in the market in the UK is by Cosmodent is Renamel, which is just a beautiful composite. Dipesh Palmer teaches it on his 2-day course in the UK, and I've been there twice now. What a beautiful composite! That shine it has. I'm yet to find another composite to give that, but that's all behind the chemistry of it. So if you just describe the differences in those two composites just briefly.
Yes. So here in the screen for those in YouTube, I have microhybrid composite, which is a stronger material because it has bigger particles. So it blocks unwanted color. It's got great flow. It's got the best tensile strength, and it's the best material for incisal edges, and is very strong for posterior teeth. So this is a slide if you guys are not looking at this, you can see in an SEM slide or a photograph, you can see big particles of filling material on your composite. And those big particles makes the microhybrid composite very strong. It's very strong. This is compared to maybe Emax or maybe something like that, very strong. But then it's microfill composite. Microfill composite is a very small filler content material. And it polishes to an enamel-like luster. It's very translucent. And it's got long-term wear resistance because the particle is so small that whenever you get one of those fillers to pop out, the eye will not see it. So they come back, your patients will come back with their veneers still polished. You don't have to polish them every time that you see them. It's very color stable. The only disadvantage is that it has the lowest strength of both of them. Microhybrid is stronger. So what you have to do is first put microhybrid and then microfill composite on top of them, and then you will have great results, just like the ones that you've seen.
Well, the only one that just to be complete for the geeks out there, the only one we haven't mentioned is a nanofilled, which is the best of both worlds, right? We can assume that that's the best of both worlds, and because I really want to get into the composite versus ceramic debate with you. So it's just good to know, guys, that these are 3 main groups of composites, and why Javier described the micro hybrid almost like the core ceramic, if you like, equivalent, and the microfill like a layering ceramic in an equivalent way. We adopt that thinking.
So nano. To follow up on your question, nano is like a blend of both of them, Jazz. And if you want to have just one material, then you can purchase nanofill. But if you want the strongest, you first put microhybrid. Microhybrid is even stronger than nano. And if you want the one that polishes the best, then you use microfill. Microfill polishes better than nano. So if you want the best results, you have to use both materials.
I agree with you fully, but what about for lower incisors? Let's say you're doing a toothwear case and you're doing lower incisors. Let's say you're doing veneering the facial and coming onto the incisal edge to build some height. Now, the incisal edge and the facial of a lower incisor is the functional surface. Like, do you, like me, shy away from using microfill there? How do you manage that scenario?
Well, you know what? I've been doing that for maybe 20 years now on composite, on lower veneers. Why? Because lower veneers, you need a lot of space if you want to do porcelain. I only do porcelain veneers on lower incisors whenever I'm raising the vertical dimension of occlusion, because then I can have a lot of space, Jazz. But if I don't have that space, which we never do have that space, then we can do a very thin layer of composite. And I most of the times, I still do all my microhybrid on the incisal edges, and then a layer of microfill in the front. And I will not get any breakage, Jazz, and as was mentioned, microfill composite wears less fast than nano or microhybrid. because of the filler is so small that wears very slowly. I don't know if you remember heliomolar, which was used for posteriors by Ivoclar. It was a great material for posteriors, and it was a microfill composite. And the wear was less on heliomolar than on their microhybrids because of the filler contact. The same thing happens with lower incisors. And I haven't done a porcelain veneer on lower incisors in so long. I do a lot on uppers, but on lowers, I stay away from porcelain because composite, I can make it even thinner than porcelain and it will last for years. They will be wearing away. I have seen patients that come back 10, even 20 years later with my composite veneers that they had been worn down after that. But they don't get a disastrous come up when a porcelain veneers breaks and then you have to replace the whole thing. So they're very long lasting, and I would not recommend my colleagues to do porcelain veneers, thin porcelain veneers on lower incisors. Believe me, I've been through that, Jazz.
Well, you raised an interesting point about when we have a lack of space and therefore you favor composite in those scenarios. I had this notion that even for composite, you need like a minimum thickness for, it's strong and compressive, but you still need a minimum thickness. But you seem to suggest that, okay, perhaps we can go thinner than ceramic. So is there a minimum thickness on the incisal edge?
Yes, you need a millimeter. You need definitely 1 millimeter, okay? And on the incisal edge. And if you get a millimeter, then your veneers will last you 10 years, Jazz. For a millimeter. Of course, if you have a grinder or a bruxer, then you need a night guard for those patients, definitely. Okay, but you will never have a composite veneer break on you on a lower incisor. You will have it on feldspathic porcelain, but you will never have it in composite. They will wear away years after, and then they come back and you just sandblast and add to them. But you don't have to replace the whole thing, which is why I love composites on lower incisors.
Well, we touched on it already now, so let's go to the big question of this episode, which is ceramic versus composite. Now, if you don't mind, I just want to share a little bit of where I'm coming from, and I'd love for you to then take it away here, is that when it comes to the debate, when you've decided that, okay, you want to go for an aesthetic enhancement and you're coming up to the decision between, okay, should we go composite or should we go ceramic? For me, the biggest player is age. Age is a huge consideration for me, and the younger the patient, the more likely I'm going to go for composite. Pretty much all of my ceramic veneer patients have been always above 50. It's just been my past. I want to know what you feel about that. However, some dentists have suggested in the groups that I'm part of that when I posted a case, they said, there isn't much enamel. I don't want to go ceramic. I'll just put composite. And in my head, I'm thinking, well, they both are adhesive dentistry. They both need good substrate. They both need good enamel. So I kind of disagree with that, but I'd love to hear your thoughts on that. So what is the decision-making tree? What are the things that you look at when you're deciding between a composite rehab and a ceramic rehab?
Well, the first thing is that older patients have a lot more wear on their teeth, Jazz. So I can do composite veneers on older patients every time that I address their occlusion. If I do not address their occlusion, then I will have problems, Jazz. Don't you agree? Mm-hmm. You have to address their occlusion. Okay? So what is that? We have to have functional occlusion. So every time that I see one of those older patients with wear on their teeth, I do a wax up, Jazz. And nowadays, it's so much easier because you can do it in exocad. You don't even need to wax it up yourself. You can exocad it, And so what I do on those wax ups is that I give my patients anterior guidance and canine disocclusion, Jazz. And with that, I am guaranteeing myself that those patients are going to keep their teeth and their veneers in well condition for a very long time. Believe me, if you do anterior guidance, disocclusion and canine rise, you will have functional occlusion and your veneers will last a very long time, Jazz. It's been a long road, but believe me, if you use the right material, which is microhybrid and microfill, and you use the right occlusion, which is anterior guidance and canine disocclusion, which is brought from the wax up to the patient's mouth with a matrix, a polyvinyl siloxane matrix. or a clear matrix, then you will get the best of both worlds. You will get the advantage of an indirect restoration with the advantages of a direct one. And I get great success with that every time that I address occlusion. Don't get me wrong, I still do a lot of porcelain, Jazz. I still do a lot of it. But I see composite as a material that has the same quality as porcelain. I don't see it as a second-tier material. I see it as a first-grade material that I can offer my patients every single day. And if you learn how to make teeth, you will definitely be able to do veneers every single day in your practice, instead of doing once per month a case of veneers or once a week a case of veneers. I have some colleagues that say, you know what, I can only do one case of veneers per week because of my lab technician capacity to do them. What if I tell you that I do one case every single day because I do them myself, or my colleagues here in my office do them themselves, And that is freedom. That is freedom. When every dentist that learns how to make teeth has the freedom to do whatever they want every single day, and not saying to the patient, I'm going to call my lab technician and see if he can have the case in 2 weeks. 2 weeks with temporaries, and then the temporaries fall, and then the sensitivity and all those problems. You don't have those problems with composite veneers, and you will get beautiful aesthetics and very long-lasting cases. I have done hundreds of cases in porcelain. Like I told you, I loved feldspathic porcelain, but then with CAD/CAMs, you don't get that anymore. You get only very thick veneers. And when you get thick
it
veneers,
seems to be a dying art.
It is a dying art. It is a dying art. And since feldspathic is dying, composite is raising. You said it yourself at the beginning of the podcast. Composite is thriving because we dentists feel the need to have control to do conservative dentistry. When my lab technician told me, you know what, I just bought a $200,000 CAD/CAM machine, and now you're going to have to prep on your veneers 3/4 crowns. I said, no, I'm not going to compromise my values. I'm not going to do on my patients what I don't want to be done in my mouth. I just go ahead and very lightly prep, maybe 0.3 or even sometimes less, Jess. And I add my incisal edges with microhybrid composite, and then in the front with microfill composite. And they turn out beautiful. They last for a long time. Of course, I have to address occlusion, like I tell you, anterior guidance, canine disocclusion, posterior support, and you have a winner. And if it's a bruxer and if it's young, it's even easier because you just raise the vertical dimension of occlusion, and then you have tons of spaces, which we can talk about that as well later on.
For sure. I mean, the immediate thing that I'm thinking already is, okay, so you're obviously a big fan of composite, but you've placed so many porcelain units as well. When is it nowadays that you will then consider ceramic ahead of that? And then also I later do want to touch on, you mentioned about the prepping. Most of the composite veneers that I see on social media are claimed to be no prep. So they will say in the Instagram description, 0 injection, 0 preparation, very proud of it, that kind of stuff. But you're obviously putting the occlusion aside. I'd love to hear from you about, okay, where does that 0.3 millimeter come in? Is that for space reasons, or is that for other reasons? If you just go into that as well as addressing, okay, well, at what point are you actually going for ceramic then?
Yes. Well, I still go with ceramic whenever I have very destroyed teeth, Jess. Whenever I have, class 3s in between each tooth and class 4s, and I have a lot of different colors in different teeth, and then I have to mask everything, and it's just I cannot fix a smile in the morning. I go with porcelain. But if I can fix a smile in one morning,
or is it veneers?
I do both. I do crowns and I do veneers, And the other thing is that also if my patient can afford it, because if you want to do conservative dentistry, you have to have a very expensive lab technician, that can do a 0.4 or 0.5 millimeter veneer. And I don't know in the UK, but here in Costa Rica, the lab technicians that can do that charge as much as maybe half of my veneer fee, you know. And so if my patient can afford it, then I go ahead and do porcelain. And if I think that is worth it, like you said, maybe patients that has very destroyed teeth or older patients, then I go with porcelain. I still do a lot of porcelain, but I was blessed to learn how to make teeth. And you know, I'm not a very dexterous dentist. I just learned how to do it. I took a plane. I went to Chicago and took all of their courses at the CAE in Cosmedent. And then I went to see Dr. Newton Fals in Brazil. And then I went to see Dr. Pascal Magnier in California. And then I learned how to make teeth. And then I practice and practice and practice and practice. And now I'm a free dentist. You know, whenever I feel to call my lab technician and say, you know, I have here a porcelain veneer case for you, I can do that. But most of the time nowadays, after 20 years of practice, I tell you, I do most of them in composite. And I'm so happy and so free because of that, that I keep doing them and I offer them to my patients. I also have, you know, I'm already 52 years old. So I've been teaching this technique a lot. So I have a lot of dentists with me that also do it. And they also have seen the value of learning how to make teeth. That also translates in posterior dentistry, in posteriors. I used to do a lot of inlays and onlays on EMAX. And you know, sometimes it's frustrating trying to make them fit, you know, the contact points and the occlusion and everything. And then I found out that I could do the direct indirect technique also in posterior teeth. And so now I make full mouth rehabs with tabletops of composite in the posteriors, anterior composite veneers, raising vertical dimension in centric relation occlusion. And I give them anterior guidance and canine disc occlusion every single day. You know, I was listening to Dr. Patel, your invited dentist, last month about full mouth rehabilitations, and he's right. You know, if you look closely at your patients, 80% of them need a full mouth, Jazz, because they all have wear, they all have interferences in the back, so they have wear in the front. And so if you raise them their vertical occlusion with just a little bit of composite, and then you give them anterior guidance and canine rise, they will have, they love you for doing that because their problems are gone. Their teeth are not breaking anymore. Their muscles relax in centric occlusion. Their joints are healthier. You know, it's such a beautiful time to be a dentist, Jazz. I tell you, you know.
Oh, that's my favorite thing. I'm always vouching for that. That, you know, now is a great time. Oh, there's so much doom and gloom, but there's never been a better time to be a dentist. I'm so glad you said that.
You know, I have a scanner now, and I look like a kid scanning all my patients. You know, and I used to say, no, you know, you will never replace polyvinyl siloxane, and now I do replace it every day, you know, with my scanner. Yeah. You know, so it's such a great time to be a dentist. It's just the great materials that we have, the adhesive dentistry that you have to believe in. Just forget about metal. Forget about porcelain fused to metal. You know what my lab technician used to tell me? Javier, you have to prep your teeth until you see pink, so that I have a lot of space for my porcelain fused to metal. You know, and I used to do that, Jazz. I tell you, I'm so regretful because I would never do that on my mother or my sister or myself. I would never do that, and I used to do it, and now. It is very rare when I get into denting, unless my patient already has crowns or already has big class 4 restorations. I stay on enamel all the time. Either if I'm working with porcelain or even if I'm working in composite, I stay on enamel because enamel is the high road, as Pascal Magnier says. You work in enamel, you're working on a high tier place. You work in dentin, and then it goes down. You do root canals, and it's even lower biomimetic dentistry. So if you stay in enamel on vital teeth, you have a winner. And that's when your cases will last 10, 20 years. You know what, Jazz? I'm going to tell you a secret here. I graduated 30 years ago as a dentist when I was 22 here in Costa Rica. And then I went to the States to do my postgraduate studies, and I stayed there for 5 years studying and working. And so I can see now my patients that I did some work more than 20 years ago. All those patients that I wrecked their teeth with crowns, they come back for implants now. All those patients that I was conservative and I did veneers on them, they come back for more veneers. So
that's a very humble admission of you. And that's very good to hear. You know, there's no better teacher than seeing your own recalls.
Than time. You know, time is your judge. And you know, I have so much enamel on my back, Jazz, that I'm regretful of doing, of prepping all those teeth. I used to brag how my preps were perfect, and I used to brag how many full mouths, 28 crowns I can do in a year. And now I regret all that because I know that technology was available, but I didn't understand it until maybe 10 or 15 years ago, Jazz.
Well, I think you're being a bit harsh on yourself, as you know, Javier. I think obviously advancements in dentistry.
Yes.
You did what was right at the time. You were practicing through the porcelain deficiency years. The whole everything was veneers. You prepped through those years, and now you've totally embraced minimally invasive dentistry, and you're a champion of that, and you're singing that. So don't worry about that. Everyone's got skeletons in their closets, but it's very a nice admission of you. So we appreciate that.
I'm trying to be as open as I can be with you guys because I don't want you guys to go through the same thing as I've been through the last 30 years, you know, which I regret doing some things. And then I found out that the golden rule is true. If you do on your patients what you would do on your mouth, then they will come back. You know, they feel that. They're not dumb. They know that you're doing the best for them. And the best for them is conservative dentistry. So I would strongly suggest it doesn't matter what material you guys choose, porcelain or composite. What matters is what are your belief cores, your morals. And what it matters is what are your principles of treatment planning. And if your treatment plan for conservative dentistry, then it doesn't matter if you do use acrylic because it will work, you know? So there are times where you have to prep, and I still prep, you know, but there are times when you can be conservative. And so if you see that you can be conservative, then you go ahead and be conservative and do that every day, and you'll be a happier dentist.
Totally agree. And, in my own experiences, I'm not doing so many crowns. I'm only doing crowns and I'm replacing old crowns. But even when I have to do a crown nowadays, posteriorly, if I'm, with the whole, I don't know if you do much vertical preparations, but the minimal amount of tooth structure you can remove now to do crowns with feather edge zirconia is absolutely amazing. But anyway, we digress. We've gone a bit big picture. I'm going to go back into little details now because we touched on it, and I know the Protruserati are hungry for this because you mentioned about doing a full mouth composite rehabilitation whereby you've got your beautiful anterior veneers with the layered with the microfill on top, and then posteriorly you've got your composite tabletops. Now, do the rules change a bit here? Now, are you aiming for more thickness of posterior composite here than on the anterior, or have you found success with 1 millimeter still because you are remaining in enamel? I'd love to know that.
Well, for your YouTube fans, Jazz, I would like to show you these preps. I was so proud of doing this kind of preps. Not anymore. Now I show this like showing a wreck, you know. Now I love to be conservative, and I love composite resins because I can be as conservative as I can, you know. And so let me show you for your YouTube fans a little bit of what we can do. I'm showing here, Jazz, a patient that came into my office that had a gummy smile. You know, she told me, doctor, I have a gummy smile. And when I look at her mouth, inside of her mouth, I could see a lot of wear. These are a lot of patients that they're in their 30s and they have a very vibrant life. And because of stress and because of grinding, they have worn down their teeth. And as you can see here in the pictures, we always ask ourselves, how much can we lengthen teeth? should we lengthen it to the gingival or should we lengthen it to the incisal? It depends on their rest position. If the rest position, they show less than 3 millimeters, then we can lengthen them incisally.
Javier,
But
can I
it
just
also
ask,
depends.
let's make it really
Yes.
tangible because I'm loving this so far. But for those who
Yes.
are watching, young dentists, some dentists are learning photography and they think they don't know how to get a good rest photo. So what do you say to your patient to get a good rest
That's a great
photo?
question, Jazz.
Lip at rest.
You know, I'm having such a great time with you. You're asking the right questions. You know, you
Please,
just tell
I
your
love it, I
patient,
love it.
say, and they will show this picture right there that you see. She's saying, and,
Amazing.
and that's,
so
that's how
is a
much
great one.
they,
Another way to do it is Emma. So it's a similar thing. And another one
exactly.
is just drop your jaw. So if you just drop your lower jaw and they just open a little bit, that's another way. And they might produce slight differences, but you get near enough the ballpark. Thank you.
Exactly. And that's just a great tool because then you'll know that you can maybe lengthen this patient maybe 1 millimeter incisally, but then when she smiles, boom, look at how much gummy tissue she has, Just. And when she has so much gum showing, then you do your digital smile design, and you see that for you to have good ratio, width to length ratio, you're going to have to lengthen those teeth, both gingivally and incisally. So I still use a Facebook transfer. Now with my scanner, I use a transfer that is digital, but I still use my articulators. I still do, a wax up, an aesthetic wax up. I still do my Lucia jig, to take centric relation, and then I can take a centric relation record in the posteriors. I do an aesthetic wax up first with my mounted models. How do I do that? I digitally smile design my patients, and I measure the incisal edge to the cervical, and I add so that I have a good length to width ratio, which is usually 75% on women. And then I do a wax up. With that wax up, I first do an aesthetic one, and I do a mock up. And with that mock up, I know that I have a winner. As you guys in YouTube can see here, you can see on the left the patient before, on the right the patient with the mock-up in place, and that is going to tell us how much we're going to lengthen the teeth. Once we have that, then we can transfer with the matrix with composite veneers on the anterior teeth. So I usually do first the gingival surgery, okay? Wait 3 months to heal. I take bone out whenever I don't have those 3 millimeters for your biological width. And then once you do your gingival surgery, then if you do composite veneers, then you transfer it with your polyvinyl siloxane matrix.
And is this just a palatal? Is this just a palatal, and then you're
this is just
freehanding the labial?
One.
And do tell us about your experiences or views on injection molding, which also seems to be going quite a huge intake as well.
It is very, very popular now, and this is another matrix. If you're looking at it, you can use this matrix for injection technique, or you can use this one for your direct indirect technique, which you only use it for your incisal edges, and then you put on the front some microfill composite. So let me show you both techniques. Yes, I have here for anterior teeth. You start with the upper anteriors. Whenever you're doing a full mouth, you add the incisal edges, and then you put a microfill composite on the front, and then you polish, and then you have your upper 6 veneers. On your wax up, you already wax up the anterior disocclusion and the canine rise, and then you do
again,
the rollers.
Javier, I hope you don't mind me stopping you in your tracks,
yes,
but
sure.
As people are you're describing it, so just to make it really tangible for those listening as well, when Javier's put the palatal putty stent, so he knows exactly where he's lengthening the teeth to, and I just want to know, Javier, in your protocol, are you first putting microhybrid as your first palatal layer for strength, or are you happy to put your microfill there for an upper incisor?
No, you always need microhybrid on your incisal edges because it's the strongest material that you have. is even stronger than your nano or spherical or microfill composite. So I would strongly recommend on incisal edges, microhybrid, and then you can layer in front for your buccal aesthetics. You can layer it with your microfill composite.
How many mil are we talking with the microfill? 0.3, 0.5?
If you're not changing color too much, you can do 0.3. If you're changing color with 0.5 millimeters, you can go from A3 to B1. It's amazing how much you can change the color of a tooth with such a small amount of composite. And if you have a dark tooth, that has a root canal, then you can use pink opaquer, which is an opaquer that covers grayness. So if you have a gray or dark tooth, you use pink opaquer first and then your microfill composite. And so every time that I have a dark tooth, I just prep a little bit more on that dark tooth so that I can put an opaque composite like this pink opaquer, and then I go with my microfill. So continuing with the full mouth, you go ahead and do the lower teeth. You take, again, the matrix. You first place in the incisal edges your microhybrid composite, and then on your buccal, your microfill composite. And then you check your occlusion to have anterior guidance and canine disocclusion. And then on posteriors, you can do the inject technique, or you can do also direct indirect technique. What I usually do is that on posteriors, I use a clear matrix, which I heat up microhybrid composite with a composite heater, and then I put it on my matrix, and then I take it to the mouth and light cure it. I do it a tooth at a time, but those are great onlays that you can do with microhybrid composite and a clear matrix. This material,
like Memosil or Exiclear.
Memosil from Culser is great. This one is called RSVP by Cosmedent or Shermack. I don't know if you know Shermack materials. They have a great material, a clear matrix material like this one, which is great. I use tints so that my anatomy shows and it looks better, like brown tint or ochre. And so you can go with teeth that are flat and worn down to have a great onlay just with microhybrid composite. And then you can check your occlusion. Make sure that you have points in the back, and whenever they're going to protrusive movements, they will have lines in the front. Anterior guidance and canine rise is so important. I cannot stress that as much. So you can do a full mouth rehab, Jazz, with composite. And on those young patients, 30-something, 40-something, that they don't want crowns, and I get them all the time. You're the third dentist, and I've been offered 28 crowns, and they don't want that because their teeth they still have maybe 50, 70% of their tooth structure. And without prepping, you can open that vertical dimension of occlusion, and you can full mouth rehab a patient without taking off an ounce of enamel. And that's what's valuable about dentistry nowadays. You can give your patients function and aesthetics without being a grinder.
Mm-hmm. I mean, the etiology is also important, I think. There's a difference between a primary erosive case and a primary attritive case. The forces, for a lower risk patient, a lower headache for the dentist, you want to be treating that primary erosive case because the functional demands there may be lower than the primary attritive. So that primary attritive patient will be producing higher forces. And although we do our material selection and we believe in the composites and we get the right thickness, minimum thickness, the correct type of composite, i.e. Microhybrid. Just like you said at the beginning, some patients, whatever they did to their own teeth, will put the same high forces through the resin and therefore an occlusal appliance. You can do all the beautiful excursions and canine-initiated disclusion, but some patients with the large masters and history of
Yes.
destructive forces need an appliance, I think.
Oh, definitely. They need to have a night guard. But another thing that I found out, Jazz, is that I used to do a lot of gold, metal, a lot of zirconia, and then I found out that it's not that you need to put something stronger than their own teeth in their mouth. you have to put something that it has this exactly the same strength as their enamel and dentin. And you know what? Zirconia is very, very tough on teeth, very tough on occlusions like that. And then I don't see broken restorations. I see broken teeth that I need to extract, after putting very tough materials on patient's mouth. So nowadays, I think about what is a material that will live with my patient for a long time and that will not harm their teeth. Put in something so strong that they will break their own teeth. And I don't know if you've noticed that we used to prep so much teeth and put maybe porcelain fused to metal, and then your restoration will last for a long time. But what breaks is the tooth inside, and especially if they need a root canal. So nowadays, whenever I'm treatment planning for a full mouth, and I see some teeth that already have root canals or already they have root cavities or root decay, those teeth, you better replace them with implants before you go ahead and try to be a hero. If you want, your restorations, Jazz, are going to last a long time, even if you do them in porcelain or composite or zirconia or gold. What will not last a long time are those teeth that are already very badly broken or badly used, like with root canals or deep cavities in between teeth, So those teeth, you might as well trim and plant them for implants before you go ahead and try to be a hero. But if those teeth are healthy, don't grind them down. You just add to them whenever you need, you can do that. I do a lot of those cases whenever I have maybe 20, 30% of enamel loss because of wear, either because of acid in their mouth, because they're bulimic, or because they drink a lot of cola. In those cases, you just clean everything up. You use a rubber dam and you micro etch them with a sandblaster, and then you can bond to them very, very successfully. Of course, you always have to refer those patients to the gastroenterologist so that they take care of their stomach problems, or to the psychiatric if they have bulimia. That's a very common problem here. So you have to first be a doctor and look at them in the eye and said, I can fix your teeth. But you first have to solve your problem, and you have a bulimia problem. So you have to solve that, because if the teeth that God, who is the mighty one, gave you, they worn down, of course, the veneers that I'm going to place are going to go away as well, because the problem that you have comes from your stomach or comes from your brain, and you need to get help. And those are things that we can help our patients. So, what? I have some patients that they come back from the doctor and say, doctor, I have this huge ulcer that I didn't know. And now I'm going to have to go into surgery. And it was showing in my mouth, or doctor, I've been going to the psychotherapist and I have stopped with the bulimia problems that I had, and I'm very grateful. So now I'm ready to fix my teeth. And so like I told you before, Jazz, it's a beautiful profession. It's a great time to be a dentist. I wish I have 3 kids. You met Maripas. I wish the 3 of them were dentists. They don't. One of them doesn't want to be a dentist. It's okay, but I recommend them every day to be a dentist, because we can help so much our people here and anywhere in the world with dentistry. We are doctors of the mouth, and this is such a great time to help people that they are stressed and they're wearing away their teeth with either chemicals or forces that are in the wrong time and the wrong position.
Very well said, and I echo all those sentiments. I'm going to go into, again, geek mode now, before we open up the floor for general discussion. And the geek in me is going to ask you a question that the Protruserati are definitely hungry for, because it's something that we've discussed on our Protrusive Dental Community Facebook group many times, which is interproximal management. I'm a mylar pull kind of guy, and I know I went to see Pascal Magnier in Edinburgh recently. He is a big fan of PTFE and just taking the composite right up to the PTFE, and he's some sort of wizard like that. What is your recommendation? What is your protocol for interproximal management to prevent the composites being stuck together and getting the nice, smooth, flossable interproximal surfaces?
There we have it, guys. My friend, Dr. Javier Quiros, amazing composites. You must check out his work. I put all the links in the show notes so you can check out the courses he does and the kind of cases that he presented. Of course, the YouTube people do get a little bit more advantage, but I made sure that any parts that aren't clear to my audio listeners, whom are the original Protruserati, I'll always make sure that your listening experience is not hampered in any way. So I made sure that anything that was too visual, I took it out and I just stuck it on the video elements only. Do join us next time for part 2 with Dr. Javier Quiros, where we're going to discuss the interproximal management. I left you on a bit of a cliffhanger there. We also discuss isolation techniques for composite veneers, how to prevent those dreaded stains, and what are the 5 P's of composite veneers. And hey, thanks so much for listening all the way to the end. If you're one of my listeners who always listens all the way to the end, thank you. If you haven't already joined Splint Course, do consider joining. It's actually as a podcast as well, because I realize that in our busy lifestyles, where do we make time for laptop education, right? Because that's the kind of a course it is, on-demand, online course. So to make it more accessible, I've also got it as a podcast, and then you use a video as a reference. So if you haven't checked it out already, check out www.splintcourse.com and enroll today. I'll catch you in the next episode, guys. Thank you so much.